Thank you everyone for joining our webinar, Clinicians as Advocates, MMRCs, and Evidence-Informed Policy. A few housekeeping items before we start. So we would greatly appreciate it if you can keep yourself on mute unless you are asking a question. This will cut down on background noise during the presentation. Speaking of questions, while we do have time allotted at the end, please don't hesitate to ask something during the presentation. You can unmute, you can pop a question in the chat, and we also have the Q&A featured enabled if you would like to ask something anonymously. And finally, this webinar is being recorded. So with that, my name is Samantha, and I am the manager of state advocacy for the Society for Maternal-Fetal Medicine. I know we have a few folks who are joining that are not part of SMFM. So for those who don't know, we are a nonprofit association with more than 5,500 members, our core membership being maternal-fetal subspecialists. We are dedicated to advancing optimal and equitable perinatal outcomes for all who desire or experience pregnancy. And our work falls under three overlapping categories: advocacy and partnerships, member engagement and support, and knowledge, education, and research. Under our advocacy and partnerships bucket of work lives our state liaison network. This is a member-led program that focuses on state-level advocacy and the implementation of state-based public health programs. We aim to harness the power of clinician leaders in each state to provide intelligence and serve as SMFM's ambassadors and advocates. We've worked with our SLN members on a number of advocacy activities, including drafting legislative testimony, submitting letters of support or opposition to legislation, writing op-eds, and more. So moving on to today's webinar topic, we are going to be discussing the important role that data and evidence play in driving policy and advocacy, with a focus on maternal mortality review committees, or MMRCs. We'll start with a presentation from the CDC Maternal Mortality Prevention Team, who will share the important role MMRCs play in advancing maternal health and how to use findings and recommendations to advocate for change. Then we will briefly talk broadly about the role of evidence and advocacy, and we'll finish with a Q&A. So I'm beyond excited to introduce our guest speakers for today. Dr. Lisa Hollier is the medical officer on the Maternal Mortality Prevention Team in the Maternal Infant Health Branch at the Centers for Disease Control and Prevention. She received her doctorate in medicine and master's in public health from Tulane University and completed a residency in OBGYN and fellowship in maternal-fetal medicine in Dallas, Texas. Dr. Hollier is a past president of the American College of Obstetricians and Gynecologists. Through her career, she has been dedicated to reducing health inequities and improving women's health by advancing women's health policy. Julie Zaharatos works with partners across the country to promote better understanding of the causes and factors contributing to maternal mortality. For 7 years, she has supported the development of maternal mortality review committees and contributed to the report from 9 maternal mortality review committees, the examination of a death due to cardiomyopathy by a maternal mortality review committee, and Changing the Conversation, applying a health equity framework to maternal mortality reviews. As part of CDC's Enhancing Reviews and Surveillance to Eliminate Maternal Mortality Initiative, or ERASE-MM, Julie provides technical assistance and problem solving for state-specific needs. Julie received her MPH from Hunter College and holds a BA in anthropology. She previously served as the Maternal and Child Health Program Director for the March of Dimes Georgia chapter and served as a member of the Georgia Maternal Mortality Review Committee from 2014 to 2016. So with that, I'm going to stop sharing my slides and share Dr. Hollier's and Julie's slides, and I will hand it over to them. Thank you so much for joining us.
Well, Julie and I are incredibly excited to be here today to update you on some of the work that we are doing to prevent maternal mortality in the United States. Awesome. Thank you so much, Samantha. If we could advance to the next slide. Why are we here? We are here because of what you see on our next slide. We have seen general increases in the PMSS pregnancy-related mortality ratio over time, and we know with the new NCHS data recently released, there have been stark increases in deaths during pregnancy and up to 42 days after. Remember, PMSS and MMRCs define pregnancy-related deaths as deaths that occur during pregnancy or within 1 year of the end of pregnancy from any cause related to or aggravated by the pregnancy. Next slide. Racial and ethnic disparities in pregnancy-related mortality are large. Black and Native persons are 2 to 3 times more likely to die from a pregnancy-related death than white persons. Next slide. CDC is enhancing reviews and surveillance to eliminate maternal mortality, or erase supports agencies that coordinate and manage maternal mortality review committees, or MMRCs, to understand why maternal mortality in the United States is not improving and to identify interventions to prevent maternal mortality. The initiative supports a national approach to collecting data and fostering collaboration that can lead to effective interventions. Next. We believe that by comprehensively reviewing every death, making recommendations for action, and acting on those recommendations, the work of maternal mortality review committees can eliminate preventable maternal mortality and also reduce maternal morbidity and improve population-level maternal health. Next. I'd now like to share a snapshot of what we've learned from Maria data. Next. The following 2 slides include data from review of 1,018 pregnancy-related deaths occurring from 2017 to 2019 to residents of 36 states shown here on the map. Not all MMRCs submitted data for all 3 years of death, and partial years of data were received. Many of you may have joined us for the SMFM webinar that we did back in October on this data release. Next. Of the deaths with a preventability determination, 84% of pregnancy-related deaths were determined to be preventable. A preventable death is defined as a death with at least some chance of the death being averted by 1 or more reasonable changes to patient, community, provider, facility, and/or systems factors. To identify opportunities for prevention among disproportionately impacted populations, it's important to look at the underlying causes of death by race and ethnicity. As an example, among non-Hispanic Black persons, cardiac and coronary conditions and cardiomyopathy were identified as the 2 most frequent underlying causes of death. When combined, these causes represent almost 1/3 of pregnancy-related death among non-Hispanic Black persons. We are not going to decrease maternal mortality in the U.S. in any meaningful way without prioritizing interventions that address the leading causes of death to those who are disproportionately affected. Next. 53% of pregnancy-related deaths occurred 1 week to 1 year after the end of pregnancy, a time when most individuals are not in the hospital. Please think of these numbers as much broader and demonstrating the need to work in partnership with other entities that touch the lives of the birthing people you serve. Next. In qualitative analyses of prior Maria data, the committees identified recommendations that were coded into themes. On average, committees made 3 to 4 recommendations for every pregnancy-related death. We have not yet had an opportunity to do this type of analysis fully with the data from the 36 states, but from initial examinations of the data, we have found very similar themes to our past reports. The most common facility and community level recommendation themes among pregnancy-related deaths are listed here in no particular order. Just as some examples, A contributing factor could be identified as access to clinical care. And the recommendations that the MMRC would be expand office hours, increase the number of providers who accept Medicaid, increase availability of group prenatal care, or lack of or inadequate transportation options. And recommendations would be strengthen or build systems that link persons to affordable transportation, or provide vouchers for non-emergency medical transportation. And finally, a contributing factor, limited experience with OB emergencies. And the recommendations could include things like implement OB emergency simulation training for emergency department staff, ensure ER staff ask about recent pregnancy history and consult with OB on call if pregnant within the prior year. We have some additional examples that I'll show you on our next slide. The most common patient and provider recommendation themes among the pregnancy-related deaths are listed here, again, in no particular order. Missed or delayed diagnosis, for example, as a contributing factor. Repeat blood pressure measurement in a timely manner when initial blood pressure is unexpected. Offer or expand non-OB provider education on cardiac conditions in pregnant and postpartum women. Increase the thorough evaluation of patients in pain and with shortness of breath. Other factors could be inappropriate or delayed treatment. Establish policies and protocols that support only performing cesarean deliveries when medically indicated, or implement a maternal warning system. On the next slide, we find the most common system level recommendation themes among pregnancy-related deaths, again, listed here, no particular order. As an example, inadequate case coordination or case management. Recommendations could be extend or expand Medicaid eligibility for pregnant women, create a quality improvement entity to manage outpatient care gaps, develop a universal electronic health record system that allows medical record sharing between hospitals. Again, these are just examples of contributing factors and recommendations that we've seen. Next slide. Using good maternal mortality data can be challenging, but there are resources you can use to better understand it. If there is any take-home point, let it be this. For accurate local data on maternal mortality, look to your state's MMRC. Visit our website at reviewtoaction.org. Click on the MMR networking map to find the contact names of individuals who support maternal mortality review in your jurisdiction. And now I would like to pass the presentation on to Julie Zaharatos, the Partnership and Resources Lead on the Maternal Mortality Prevention Team. Julie?
Thank you so much, Lisa. And thanks again to everyone for having us here today. We're always really glad to connect with you all. So for my portion, we're just going to talk a little bit about data dissemination and data to action. And if you go to the next slide. I think that some of these prompts are really helpful to think about what you need in order to prepare to talk about some of your maternal mortality review committee data and work in your state. So here are the prompts, right? What is it that you're trying to make true that isn't true today? So essentially, what is your goal? And then think, who is it that needs to believe something in order to move toward that goal, and so on. So I think this framing can be helpful as you review your maternal mortality review committee report in your jurisdiction and think about what you might like to prepare in the work that you do to end preventable maternal mortality. Next slide, please. So here we're going to talk through just a few examples from states. The Utah Maternal Mortality Review Committee prioritized a recommendation to educate providers on available mental health resources and specialists they can refer patients to in the perinatal period. And so in response, the Utah Department of Health launched a Utah Maternal Mental Health Resource Network. They also built an Instagram page. Maternal Mental Health Utah is the handle. And I find it quite amazing that that Instagram page has such a strong following. I don't know if you can see it here, but if you zoomed in, the Instagram page has over 7,000 followers. And it's a really nice tool that I actually follow myself in my Instagram. And they have nice visual cues that when I'm scrolling through my feed, I can instantly recognize information that they're disseminating about maternal mental health in Utah. Also pictured here is the website that the Department of Health runs that was launched in February of 2020. And in that first month, they received 1,300 visitors. So there is a desire for this information and getting it out there at the state level. Next slide, please. Here's another data to action example from the state of Illinois. Pictured here is just a thumbnail of their report that they had released and done quite a bit of work ahead of that release to engage stakeholders and state leaders on what was in this report. And then once it was released in October of 2018, there in that state legislature, 15 bills were drafted and submitted to address maternal morbidity and mortality. And ultimately, one of the actions that Illinois undertook was to extend Medicaid coverage for postpartum women out to 1 year. And so I think that this is a really strong example that there are other states that are doing this as well right now. Here in Georgia, that has also gone ahead. Next slide, please. And here's an example of data to action from Washington that some of you may have heard about in your states if you're involved in your maternal mortality review committee. When these review teams are looking at cases, it can be very difficult to deliberate on, for example, pregnancy relatedness or underlying cause of death without an autopsy report. And so the state of Washington pursued legislation to help make it so that deaths during or within a year of pregnancy were referred to the local coroner or medical examiner office so that an autopsy can be undertaken. So they passed a law requiring birthing hospitals and centers to refer deaths to women who are pregnant or who have been pregnant within 42 days to the local coroner or medical examiner's office. And they provided a funding source for these autopsies. So that's a data to action example that is kind of like a process action, but has been really helpful to that state, and other states have been modeling this one as well. Next slide, please. And here's an example from Tennessee, where they put out their data in a long form narrative, but they also put together short one-pager infographics. And you can see what's highlighted here, what healthcare providers can do. And some of these things may sound familiar from what Lisa just talked through in the qualitative data. But the examples that Tennessee highlighted in this data brief that's pictured here is to develop protocols for interpersonal violence screening, implement systems of care for mental health disorders, implement education on implicit bias for staff, provide consistent screening, assessment, and treatment for cardiac conditions, and increase access to naloxone. So you can see there, they had over 80% of the deaths that they reviewed were determined to be preventable, and the recommendations are as diverse as the causes of death themselves. But these are some powerful examples out of the state of Tennessee. Next slide, please. So this puzzle piece is visual, some of you may have seen before, but we really think it's important for data to inform action. And so we can fit together these pieces, that these maternal health care standards, tools, resources, safety bundles are fit together with an understanding of the leading causes of pregnancy-related deaths in your respective jurisdictions, because they're different for every state and for the population that you're targeting. Also at the lower left corner, prioritization of right place, right time interventions informed by the Maria analyses. And we just showed you example of the national Maria analysis that was released last fall. And then fit together at the lower right, last but not least, community engagement. It's really important to engage those communities I think many of you have heard the saying, nothing about us without us. Engage those communities. They have answers to on how we can prevent these deaths. Next slide, please. And I'm just going to spend a couple slides talking about PQCs or perinatal quality collaboratives. I think many of you are familiar with these groups, but they are state networks of multidisciplinary perinatal care teams and public health professionals working to improve population level maternal and infant outcomes statewide. PQCs work across the state, convening stakeholders and engaging and providing technical assistance to hospitals to implement quality improvement. Next slide, please. Here at CDC, we really love our maps. We'll show you a map of currently funded by CDC perinatal quality collaboratives. So you can see a bunch of different logos here, but in 2022, which was the latest iteration of CDC funding, CDC is supporting 27 states, as well as the national network of perinatal quality collaboratives that is hosted by NICHQ. Next slide, please. And this is my second to last slide. We just wanted to share some information about a campaign that you may have already heard of, CDC's Hear Her campaign. This effort seeks to reduce pregnancy-related deaths in a few key ways. It's focused on increasing awareness of urgent maternal early warning signs, empowering pregnant and postpartum people to speak up when they have health concerns, and encouraging those supporting pregnant and postpartum people to engage in conversations and support them in getting medical care when they share concerns or experience warning signs. And lastly, to improve communication between healthcare professionals and pregnant and postpartum people. So there's a suite of materials that CDC has available at cdc.gov/hearher, where healthcare professionals can pull down pamphlets that can emphasize the importance of listening and asking if they have been pregnant or have been pregnant in the last year, what concerns they may have. And there's information there for obstetric providers, pediatric providers, and other healthcare providers. And the materials include posters, palm cards, shareable graphics, and a social media toolkit. There's some examples pictured here on this slide. And we just want to say thank you. Thank you again for your time. We're happy to answer any questions. If you go to the next slide, Samantha, you'll see our program email address is erasem@cdc.gov. I am actually the human that checks that mailbox. So we're always happy to answer any questions and happy to talk more today. Yeah, I'll pass it back to you, Samantha.
Thank you so much, Julie and Dr. Hollier, for that really thoughtful presentation. I know I can speak for everyone on this call when I say the work you both are doing is incredibly important and appreciated. Before I jump into the rest of my presentation, I just want to pay attention to the chat. It looks like somebody asked just now, can you comment on the WHO report on maternal mortality? And I think that might be for Julie or Dr. Hollier.
Are you referring to a World Health Organization report on maternal mortality? Yes. So I actually don't work with WHO on that, so I don't know that I can say much about it.
I'm afraid I cannot either.
Well, that was an easy answer. Unfortunately, not one that you were hopefully looking for. But with that, I am going to share my slides again. If you just give me one moment. All right. So again, thank you to Julie and Dr. Hollier. Before we head into the Q&A portion, I want to just take a step back and talk about some best practices around using evidence to advocate for policy change more broadly. So when it comes to using evidence, to inform policy changes, a critical first step is evaluating where the change needs to happen. And so in their presentation, Dr. Hollier and Julie showed a handful of charts of patient and provider level changes, systemic changes. And so this is what we're talking about, identifying where what the evidence is saying and where the intervention should take place. So for today, I'm just going to talk about two different levels. First, sometimes change is necessary or best achieved at an institutional level. Perhaps there's something at your specific hospital, a policy or practice that needs updating to improve patient health outcomes. We also see that change is often systemic in nature and not due to one institution, but rather a range of institutions or even greater at a legislative level. More often than not, change does not come down to one level or driver, and is rather multiple interventions are required to fully address a complex problem. With that said, it's still important to understand what the evidence is telling us so that we are advocating for solutions that can have the greatest impact. For example, advocating for a change at a single institution when the problem is systemic in nature is not going to have the wide-reaching progress we seek. That's not to say that you can't and shouldn't advocate for change at your own institutions, but rather that your advocacy should not end there and that we should seek for greater progress. So once we know where to intervene, we can develop interventions and solutions and then advocate for them. So just like with any advocacy, the first step is identifying other stakeholders and building relationships with them. So as we heard in the previous presentation, stakeholders often include those who are impacted by the problem we are trying to address. They also include individuals, coalitions, and organizations who are already working on solutions for the problem at hand. And finally, those with the power to implement change. So they can be legislators, Department of Health officials, hospital administrators, etc. So relationship building is key to not only establish partners and share resources, but also to establish trust with the communities most impacted, as well as the people who have power to implement these changes. You need that trust with communities so that there is an open dialogue, and you also need that trust with the change makers so that they understand your expertise. While in some cases, you may be advocating for policy change that's already been proposed or suggested, in other cases, you may need to work with partners to determine what these solutions are. So the big question is what interventions can achieve the change we desire. But we also need to be honest and see if those interventions are feasible and sustainable. So when I talk about feasibility, I don't necessarily mean whether it's feasible that a policy is passed or implemented, but more so, I mean, do we have the resources to see these interventions and solutions through? On sustainability, similarly, we want to make sure that what we're doing is not a Band-Aid or a quick fix that doesn't really get at a root problem. So I think a great example, if we turn back to MMRCs really quickly, is reporting requirements of MMRCs. So if your state's MMRC hasn't put out a report recently, someone might jump to introduce and pass legislation mandating regular reporting to fix the issue. And while we love regular reporting and we love accountability, this may not actually fix the problem and may cause more problems. So SMFM staff are actually working with our members in one state to address this issue. Their MMRC hasn't published a full report in almost 10 years, and the data that they've reported on is even older. And the solution here is not to mandate their reporting, but to see why they are delayed. And so we found that the issue is not a lack of will, but a lack of resources and bandwidth. And so we're working with them to ensure that they have the tools and the resources they need, including additional abstractors, epidemiologists, and support from their Department of Public Health to make sure that they can get through the data and they can put out findings and recommendations that are relevant and updated that then can be used for advocacy. So once you've established your intervention and once you've developed relationships, you can move on to developing messaging and communication strategies with your partners and coalitions on the ground. So I think as clinicians, it's important to remember that not everyone can understand the medical and the health research that you're using in your advocacy. So a critical first step is making sure that you're translating your research into information that is digestible to common audiences. This doesn't just include policymakers or Department of Health administrators, but also the communities that you're advocating for. And again, this comes back to that level of trust established, because they need to know that the research you're citing is in their best interest. So this will also help to clarify what messaging will be most effective when trying to reach those who have the power to implement policy change, because as we know, it's not always, the data we have is not always the most palatable in every way. And so understanding what parts of the data are going to reach policymakers is really important here. And so I want to go back to one of the examples that Julie shared previously, perinatal quality collaboratives, or PQCs. So comprised of diverse range of stakeholders, PQCs use data from MMRCs and other programs to advance policies, practices, and processes on multiple levels. And the work that PQCs do shows that, one, change does not have to involve the legislature. It can be on an institutional level, it can be on a systems level of institutions, or it can include legislation. And two, PQCs show how important and valuable it is to work with a range of partners, including those who are part of the community most impact. It's having these relationships and having this trust that really helps PQCs be successful in the work that they're doing. And so before we turn to the Q&A, I just want to remind all of our SMFM members that our staff are here to support you, and that we have the expertise to help you think through issues, identify policy solutions when needed, make connections with stakeholders, and help develop and execute your advocacy plans. And you can submit a request for support on our advocacy hub at smfmadvocates.org/request-support. So with that, I'm going to pause my screen sharing and open it up for questions to myself or to Julie and Dr. Hollier. And I see we have a couple in the chat, so why don't we start there? Dr. Smith said, one thing I've been hearing recently in Utah and others is that MMRCs are not great at communicating recommendations back to community clinicians. Would love to hear Julie's thoughts and others' thoughts on effective ways of doing this. Oh, Julie, you already started to comment, so I'll let you jump in.
Julie, did you want me to start off and then you can, okay. I think this, Marcella, first of all, hello, it's good to hear from you. Thank you for all the work that you do. We love you. I think it's incredibly important that MMRCs really think about the information that they're putting out, as Julie mentioned, and she had some really great examples of developing resources like they do in Tennessee that are compact, contain important information in an easily consumable fashion. So I think that's one great example of what an MMRC could do. I think ACOG and SMFM doing things just like you're doing are potential ways of getting information out. I think we also, I think we can also do things to support the fact that it's a two-way street, right? We want to build interest, just a general interest within clinicians in the communities about what their MMRCs are doing. And that's in part what we're trying to do today, is to make everyone aware of where you can go to find this information. And those local MMRCs really are a great source of information specifically for your state, for the context in which you're working. Julie?
Yeah, thanks, Lisa, and thanks, Marcella. You're such a great partner in this work. I mean, I have to agree. I put an example in the chat from Tennessee on how they're putting out briefer infographics. Everyone is busy. They don't have time to read a 100-page report. So we are working with states and our technical assistants to maternal mortality review committees on modeling some templates, some data briefs. You know, policymakers, they don't want to know how the clock is made. They just want to know what time it is. So trying to just put all that methodology as a reference and then give them something quick, something they can use to take action. So I think it's a very good point. And I think that we can help lift up examples in states that have done a good job. I mean, I think Utah had a nice brief report, and I think it made a big splash, right?
Yeah, I guess that's I think we've worked on these brief reports to get at, nobody wants to read 100, right? Like, unless you're an MMRC nerd, no one's going to read the 100-page report except the people that are doing it. Yeah, we'll just own that. But I think the brief reports are great, but I don't know, because this was really recent feedback, that, clinicians were like, we have no idea what you guys are doing. And so I'm not sure that I wonder if those brief report, like, the dissemination mechanisms that are actually getting the brief report to a clinician in, down the street in a community hospital. And I just don't know if we're struggling with, because we just got recently that feedback. And I talked to somebody in Illinois who kind of was hearing the same thing, that these brief reports are happening, but if they're actually making it to the eyeballs of clinicians, and what are the effective dissemination mechanisms? I think the brief report's the right tool, but how do you get it to them? And I don't know the answer to that.
I see some other MMRC members on the line. Do any of you work with your PQCs to try to push info out to providers or your local chapters? I'm curious.
Crickets. So maybe this is a common problem. And I'm going to think, so this is helpful to sort of think about, because I wonder if, like, the same people that are involved in MMRCs are often involved in PQCs and those folks, but that, I don't know if, like, the local, our district, like our ACOG districts or our ACOG, but it's also, especially here in Utah, we have lots of family medicine providers that are providing obstetric care. We have lots of midwives. So, utilizing our other professional organizations.
Marcel, I think too, like, for folks that are on this call that sit on an MMRC, I think that the State Liaison Network can be a tool for that. I think just like we're having this webinar today at a national level, I think to the extent that there is an interest in having a state level kind of dissemination, kind of discussion webinar, I think we can help facilitate that. And there's folks on this call that are part of our provider clinician community outside of SMFM. And so, like, using this model at a local level is something that perhaps SMFM could do, given that so many of our members are leaders in this work. So at least, like, that starts that process. So I just wanted to offer that as an opportunity.
And more on the role of SMFM, we are part of coalitions with other medical societies that reach other practices. And so, happy to share those out with them and have them share with their members as well. Obviously, it's not a long-term solution, but it is a way to at least start those conversations and maybe help you build relationships with folks in other practices in your state. Any other comments on that? Well, looks like
Sorry, Samantha, I was reading ahead in the chat, so go ahead.
Well, I was just going to read the question. I think the next one we have is, perhaps more of this information or these briefs could be added to the ABOG reading list for maintenance or certification. Great idea. Seems very pertinent to improving practice. Thank you. And then the next comment, I'm in clinical practice and have both presented the MMRC summary report and department meetings and adopted aspects of our recommendations as part of standard phrases in my outpatient consult notes. Barriers so far have included staff attendance at meetings and referral of patients for consultative care.
I think that's great. And I don't know if many of you were on the webinar that Lisa and I presented in the fall, where we presented the more in-depth look at the 36-state data. And I would just, during that session, we kept reiterating how important it is to look at your own data in your state, but also to understand the disparities. What are the leading causes of death to the population that's most affected in your state? It may be Native women, it may be Black women, like here in the Southeast and nationwide, Black women are disproportionately affected, Native women are. Here in the Southeast, the states have opportunities to look at the leading causes of pregnancy-related death to Black women in their state and consider opportunities to prioritize interventions that address those causes. We think that that's a really important perspective to think about in your prevention work, because we're not going to make meaningful change in pregnancy-related mortality in the US if we don't address the leading causes of death to those who are most affected, sorry.
Thank you, Julie. There are no more questions that I see in the chat, so want to open it up if folks want to unmute and ask questions or offer other comments to the questions that have already been posed.
I might ask a question just as folks are thinking. I think it might be helpful for us to hear kind of what you're thinking about, like your dreams and hopes for MMRCs and the work that CDC is doing in the coming year or years to help support states, and what you're thinking about, and as you're reviewing the growing body of data that's coming in from states and how you can support them.
Are so many hopes and dreams for the coming years, and I think we are really looking at modernizing our data systems and helping data to get into the hands of folks like all of you on this webinar today who need that information. We continue to work with the MMRCs to provide technical assistance, assist as much as we can in standardization of data collection, entry, analysis, provide support for different types of analyses, and working with MMRCs. Well, Julie, you can talk about some of those. I'll just say one more thing and then I'll let you talk about some of the other things. It's very important to be sure that we are looking at the full context in which people are living their lives. And so being able to incorporate social determinants of health in information on the environment in which the decedents have lived is really important. And so we're working with partners to ensure that maternal mortality reviews can have access to that type of data. Julie?
Yeah, I mean, I would just build the hopes and dreams are that people would understand the power of this data, and that also the health department teams would be capacitated to get out the reports, timely and in a way that's easy for stakeholders to digest. I think we talked a bit about qualitative data today. The real richness of the MMRC data is in those narrative stories. There are some really powerful and of course very tragic stories behind those numbers. And if we can help capacitate the state teams to aggregate those stories. All of this is de-identified. You can't disclose, something specific about a decedent name or the facility that she was at, but there are tools we can use and lift up to help them tell those stories in a way that will resonate with the public and help them understand opportunities for action. The Illinois report does a good job of including some vignettes of causes of death by race and ethnicity that I think were really helpful for the media and for legislators to understand what was happening and what the data were really telling them. So I think that we will continue to work with teams to try to get the data out in a more timely fashion and in a way that's easily understood.
Thank you so much. And we'll give space if anybody else would like to unmute or pop any last questions or comments in the chat. Okay, well, seeing nothing in the chat and not hearing anybody unmute themselves, I think we can conclude our webinar for today. I want to thank everyone for joining, and especially Dr. Hollier and Julie for your wonderful presentation and all of the work you do. I know everyone, including myself, is just very grateful, and we look forward to a continued partnership. And for SMFM members on the call, if you're not already part of our state liaison network, we encourage you to sign up today using the link on your screen or the QR code. And this is the best way to stay up to date on SMFM's advocacy work, as well as opportunities to engage in your state. So thank you all very much and enjoy the rest of your afternoons.